Life brings pain, but for some people the pain is sharper and may never go away.
It's straight, so it causes a lot of headaches and a lot of pain.
This time, On Call examines living with acute and chronic pain. The doctors are on call tonight.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Go hard! Whoa, whoa, whoa! Keep pushing.
Position your head.
Pull red handle to open bag.
Good evening, everyone. The term rehabilitation can mean the restoration of an old building or an old part of town to its former good condition. My family did that with an old house built in 1900 by lifting it up, putting under it a new foundation, replacing the windows with double glass tight ones, and putting back a wraparound porch that was like the original, which was removed years before we moved in. In many ways, this old house was better than the original. Tonight, we are not talking old houses. We're talking people who have been injured by accident, war, or age, who are suffering from dysfunction, disability, or pain. And we're talking rehabilitating and restoring people back to their former good condition. We invite you at home to call any and all questions about acute and chronic pain that you may have. Our phone number is 1-888-376-6225. Again, 1-888-376-6225. Rehabilitation services include physical therapy, occupational therapy, speech therapy, pulmonary and cardiac therapy, and more. But also there are whole specialties of medicine that concentrate on repairing broken bodies and returning them to normal function. Two examples of such specialists are here tonight. Dr. Jim Hoff works at the Sioux Valley VA as a specialist in physical medicine and rehabilitation, and Dr. William Cohen works at the American Pain Relief Institute located in the Avera Sacred Heart Rehab and Wellness Institute as a specialist in pain management. Welcome, gentlemen.
Thank you.
So let's just talk a little bit about who we are. And Jim, you're originally from DeSmet, of course.
It's part of the connection.
That's an important thing. But tell us about your specialty and where you came from and what you did.
Well, I'm formally called the term a physiatrist. And physiatry is, the best I can explain it, is kind of between orthopedics and neurology. But we deal with a lot of musculoskeletal type injuries. And I think when I discovered it, I was in medical school at the time. There was only like 2 in the state at the time. Now we have at least over a dozen that are here, and we work with a lot of interesting things.
And you're working at the VA. You've been there for how long?
Oh boy, 11 plus years now.
All right, so that's great. Now, Bill, tell us about yourself.
Well, coming from New Jersey, you can understand how I can specialize in pain. But my basic training was internal medicine, then general surgery, then anesthesiology, and then in interventional pain management. And when I first moved to the Midwest about 14 years ago, got involved in radio frequency therapy. And that happened after I took a course at Harvard where I met Menno Schlauter, who is the foremost pain specialist employing radiofrequency in the world. And listening to what he had to say and a few others, I flew over to Holland and spent some time there learning the techniques that they employed. And that's what I use in the United States.
Well, and you deal with pain in many ways as others aside from radiofrequency, but that's your major...
You bet. The key is, I guess the major thing in managing pain is figuring out why it's there. What I am involved in primarily is a consultative service, trying to find answers rather than patients to perform procedures on. And if you can figure out what the problem is, then you know which way to move.
Right. And what we have now is a topic of chronic pain syndrome, rehabilitation. We have Jim here who is dealing with or helping to help people deal with the rehabilitative factors after Iraq and Afghanistan wars. And Bill, you're out in Yankton and dealing with people across the board, VA patients as well as non-VA patients with chronic pain. So it's really, the issues are wide open. Very quickly, gentlemen, tell me what's the difference between acute pain and chronic pain? Jim.
Well, if you want to buy textbook on there, anything that goes anywhere from 3 months longer or longer than 3 months is considered chronic. Acute phase is more than that.
Bill, any other comments?
Yeah, acute pain is something you need to stay alive. If you're going to put your hand in a fire or step on a tack, sit on broken glass, you need to know about that. That is essential for life. Chronic pain is not. Chronic pain is something like a bad marriage. You want a fast divorce. You want to get out of it.
You don't want to stay for a long time.
No.
So, and it's certainly one of those things. It's once somebody, it's sort of like it comes in and it sets in and it doesn't want to leave. And
That's
some
right.
people just have to live with it for all their lives.
Well, unfortunately, that's the thought, and our job is to find ways that they can get rid of it.
All right, we've got questions already. Here is, I can't see where it is from. Custer, kidney removed in 1998 for non-malignant tumor, has had pain in that area ever since. Can anything be done? Either one of you. Jim.
Oh, I think there are things that could be done on there.
What?
Well, thorough exam for one on there, but you're looking for the location on there. A lot of the times, entry and exit when they're removing the kidney usually has a neuropathic base to it. Wouldn't you say, Bill?
Yeah, I would think so. The key is understanding what kind of pain there is. The patient says, had pain since the kidney's out, but we don't know the nature of the pain, the duration of the pain, where it is, when it is, how severe it is, what makes it better, what makes it worse, all the basic questions.
If you were going to be a guessing person, and that's what we're having to be here, would you guess that this is, that a nerve was cut or irritated and it's just sitting there, or is there a possible infection in there, or do you think? What would be your guess?
I wouldn't think it would be an infection. I think it probably would be with the nerve, as Jem said, probably neuropathic. Need more information from the patient, but following through with that, yeah, that would be the way to go.
So let's say it's a neuropathic pain and you'd treat it with something like Lyrica or gabapentin and it's better. Is that something that would lend itself to your kind of intervention?
If you did those things and the patient was better, you wouldn't need me.
Okay.
Yeah. You know, there's medication, non-medication things. You can look at things that fool the nerves. TENS unit, for example, sometimes mask the pain and actually overstimulate it where it settles it down. That's a relatively easy fix. That usually gets done before it gets to me.
Okay.
But
and what's a TENS unit?
A
low-grade little nerve stimulator?
Yeah, transelectrical nerve stimulator.
Through the skin.
And it's just 2 patches that apply to the skin. They usually come with 4 now. They set it to different frequencies and try and find one that settles the pain down if possible.
It's a kind of electrical low-grade shock that's running through there.
Yep.
And sometimes that helps. How about pepper cream? What is your experience with pepper cream for such a thing? Pepper cream, capsaicin cream, and it burns the skin somewhat, and that burning seems to decrease the pain. Have you had experience with that?
Haven't used the pepper cream, but I'll tell you what, our friends that are Native Americans have great experience with use of different herbs that modify the way the nerves work, raise the amount of stimulation you need before you recognize pain. And that's how these things work. It changes the action potential in a way for when the nerve will fire when the pain is recognized. And that's, I suppose, an oversimplification, but basically the mechanism of how that cream works.
Right. I mean, a thing that's hypersensitive, you overstimulate it so that it wears out and it gives up the fight.
Yeah, the capsaicin cream is just a neural depleter, the little ends of the nerves.
Yeah.
And you have to use it continuously on there or a daily basis. And the thing I find out is they'll try it periodically. You have to use it regularly. You can give it about a 2 to 3 week run of using that and then applying it.
So but you've got to use it and you've got to give it a significant time to trial.
Yeah. With it depleting the end of the nerves of all the transmitters, that you got to keep after it for a while.
All right. We have a good question about morphine addiction and another one about spinal stenosis. We'll get back to them. Chronic pain develops for many reasons. Sometimes it's due to result of having a condition that developed from a previous injury or medical condition. For instance, diabetes can lead to the amputation of a foot or a leg that then presents with its own unique concerns.
In 2007, I had diabetes before that, and my feet got bad, got them ulcers. And when they got the ulcers, I went to Holmes, and he said they're getting worse, and so we operated on my left foot and took out part of the bone. And that kind of healed up, and then I got it in my right foot. And then we had, got bad, and so they sent me to Sioux Falls to have it amputated. And I had that done, and of course it's real hard to sign the papers. But when I got it done, I was laying in the bed, and I figured, man, this is going to really hurt. And it hurt a little the first night. They had morphine pump. And the next morning, I never felt a thing, and I've never felt anything since. After, I'm going to say about 2 months, then I got down to Sioux Falls to get my artificial leg. And that was a little hard to get used to. And I think the main thing that I've found out, you can't think about it. You've got to you got the new leg on there, and you got to try and make it work the best you can. I love to hunt, and of course it's gotten to where you just can't walk now for that. I just kind of miss that. As far as the leg, the only time I have to go down there is if I get a new pair of shoes, or there's a cover that goes over that holds your leg on, and that gets in bad shape after a while. And I need to go down there in the next 3 weeks and have a new piece put on. I would say I probably did adapt to it, and like I say, I missed some things like walking. To walk out across the lawn and the grass, that's kind of rough. But if it's hard gravel road, I can walk on that pretty good.
It's a great patient, a wonderful friend, and we thank you for sticking your neck out and being on our show, Paul. This is a man who's given an example of losing a leg from diabetic ulcer and subsequently surviving and getting back to function. You deal a lot with amputees. Do you see that there's some people who just can't get back to it, or are most people able to get to a walking?
The majority get back to walking on there. You have to look at unique issues of what's stopping them, or what's the biggest problem. Is it pain, fit, repeat ulcer, type of infection? Do they have heart or respiratories that hold them back too?
Yeah, yeah. So you said pain or fit of the artificial limb.
Yeah, usually they'll go through limbs a couple of the first year because it's busy shrinking and reshaping or remodeling.
Oh,
and if they start shrinking from the swelling, they get fit too quickly, or the wounds aren't all healed, then they start bottoming out a little bit. It could be very painful for them.
Yeah.
That's an easy fix.
So you make it fit, you make it without ulcers, and people can actually walk on these. How many of these gentlemen are coming back, or women coming back from Iraq and Iran that have lost a lot of limbs? Or, you know, what are you seeing? Is it worse than you've ever seen? Or?
I'm seeing unique injuries coming back, things that I've not seen in this amount in my practice before. There's a special type of lesion that develops bone from an explosion injury into the skin. And I think part of the bones are getting deposited in there. We can't dig it all out. And they're growing extra bone in there. It interferes with the fit. If it's close to the nerve, it can be very painful.
So pieces of bone that are blasted into the tissue, and now it's growing more bone. That's an amazing.
We don't understand that theory totally, but the topic's called heterotopic ossification, but it's just bone developing in areas you shouldn't be seeing.
And it gives you trouble.
Yes.
So what would you do? A second surgery, redoing the area where the leg was amputated initially, second amputation?
I've seen some of the guys that have been coming in from Walter Reed. Some of these guys are magicians and really truly craftsmen at doing some of the amputations. It's some of the best work I've seen in a long time. But I think they're seeing numbers, so you get good at it. But I had one gentleman that had repeated extra bone growth in there. He went through 4 extra surgeries just to reshape it and refit it so we could fit him. But I'm following, I have easily over a dozen gentlemen that I am following on there that have this unique condition.
And how many people are you following that have had amputations?
Oh, I have a few dozen that have come back from explosions on there that have been caught by these things.
All right. How can you get over morphine addiction? This is one question that I'm sure as we deal with people who have pain, one of the medications that we provide is a narcotic. Narcotics are our mainstay in pain relief, but there are people who become dependent on it.
Right.
Bill, you deal with a lot of those?
Well, I don't, but back in the days when I had the privilege to do some of the things you do, when I trained in internal medicine in New York City, there were different types of morphine addiction. You would have the patients that were iatrogenically addicted, in other words, had an addiction because there was a pain problem. The doctor gave them medication, they needed more and more, versus the type of patient who came in because it was a joy seeker who got involved with one type of medication on his own or her own, and then switched to something more powerful, then became addicted to the medication, such as morphine. And there were a few different ways of dealing with it at that time, which was either taking the patient off completely and putting them in a room, which is not good. It's a good way to develop seizures, or to use other medications after evaluating the patient and gradually withdrawing them from the narcotic, along with psychiatric and psychological therapy to help them learn to deal with themselves and their problems.
Oftentimes people who become addicted to these medications need the help of the physician and the understanding.
Right.
The problem is that some of them want more. And physicians are all being monitored. We're all being watched. There's a state registry happening right now. Do either one of you know more about that?
Well, I think we were involved with that a couple of years ago through the State Medical Association. I'm not certain that the registry is run through medicine. I think it's run through pharmacy. But the original intent of it was to help the patient by making certain that when a patient came to us, we had access to the information regarding how many other states and how many other doctors the patient had seen,
and how many other pharmacies,
and how many prescriptions were filled, because we don't want to kill anybody by giving them too much medication. We're there to help the patient, not to injure the patient. And every doctor has that great desire to help the patient not suffer. I mean, after all, what is medicine? It's the idea of relief of pain and suffering besides curing illness. And with our zeal to try to stop pain, Some physicians go to what's immediately available, which is medication. My practice is otherwise, it's interventional. We try not to use medication unless there's broken bones or cancer.
Yeah. Jim, any comments?
Well, my advice is at the point, one, they got to be true to themselves. A good assessment's really important from the standpoint. I look at it and deal with it quite a bit. You know, is it just the morphine? Are there other medications for like polypharmacy issues?
Yeah, many drugs on board.
Yeah. You know, mixing alcohol, other things that illicit drugs, as well as the combinations of benzodiazepines or like Valium with the morphine. And if it's just straight the one, then you have to figure out, is it a dependence issue? Is it a tolerance issue treated for a condition, or a true addiction?
Yeah. Challenging topic. We could go all night on that topic.
Yeah.
Well, if the patient truly has a pain problem to begin with, then the answer is not which medication to give, but to figure out where the problem's coming from and deal with it. If it is an issue where the patient has some sort of problem that will be relieved with medication, then we go with that. But you want to find the simplest way to deal with the problem without addicting the patient.
There you go. And then you have to, as you said, the narcotic is a cover. What we really should do is deal with the problem. The problem is, however, that sometimes we don't have a way of getting at that basic
It's always
problem.
a challenge.
You got somebody with a fractured hip and they're waiting to either get in surgery or they have no surgical resolution and have to be able to move.
Well,
you know, there are obvious things.
Right. Well, narcotic has a role for that.
Yeah.
It's a tool. That's all it is.
Someone asked about shingles-induced post-herpetic neuralgia. Bill, you probably deal with post-herpetic neuralgia.
Yeah, all the time.
Explain what it is.
Well, you know, when I was in medical school and I was trying to remember the terms, and we came up with the mnemonics, my wife, Dr. Leslie Hershkowitz, who's a cardiologist, said it comes about because of a varicella virus. And varicella is with chickenpox. So the way to remember that is chicken varicella, like the topping of spaghetti. And once you get over your chickenpox, the antibodies from that are in your body forever. And it's a question of at what point are you under so much stress that there's a reemergence of this problem. And it attacks nerves, and when it does, it causes, along that particular nerve pathway, these sores that sometimes are weeping sores, and they look like shingles on the roof.
Yeah.
So they're called shingles. And the question is, how do you stop it? And there's a variety of ways. First thing is using antivirals. Second thing is anti-inflammatories, pain medication, and sometimes using steroids. If the shingles go away, but you have continuing pain after the shingles heal, then we look at the nerve, and that's where pulse radiofrequency is very helpful in relieving the pain.
Very good. That's an answer. We all take care of small day-to-day pain. Often we utilize one of the varieties of over-the-counter pain medicines. There are still concerns with these drugs, as well as the prescription drugs that we prescribe for more severe pain.
A lot of what you see is starting out with your over-the-counter medications, those that you can get at Hy-Vee, Lewis, Walmart. They're easily accessible. You don't need a prescription to get them. They start with medications such as like acetaminophen, or Tylenol would be the name brand for it. Ibuprofen or Motrin would be another one that patients often use. There are also other medications to Bayer back and body that have Motrin in them. There's also some that are like Tylenol PM that maybe have, you know, the pain portion of it, but then maybe have something to help patients sleep at night. Like the Aleve or Motrin, or ibuprofen is another name. They call it an NSAID. It means it's a non-steroidal anti-inflammatory drug, and it's a drug that's in your body that helps kind of get rid of pain by decreasing inflammation in the body. You know, a lot of times patients will switch over from over-the-counter to prescribed when the over-the-counter medication isn't cutting the pain. They're not getting relief from it. A lot of what I see is the patients will switch over to such medications as tramadol. That's a common one that patients use for pain. Also to our hydrocodone with Tylenol in it, or Vicodin or Loratab would be the other names that these medications go by. And they're a little bit stronger medication. You know, they are going to be a lot stronger than what you can get over the counter. One thing though we do warn patients with, like with your Lortab, with your Vicodin, they do have a Tylenol component in them. So as a patient, you do have to be careful that you're not mixing over-the-counter medications with Tylenol in them along with these prescription medications, because then you can kind of get into trouble because you're going over your daily Tylenol limit. Usually for chronic pain, we will move up a class of medications to our opioids, such as like Oxycontin or Oxycodone would be the generic name, or sometimes we'll see fentanyl patches too. Fentanyl is another narcotic that is used. You know, a lot of times what I find is patients will come in and say on these medications, especially for chronic use, they're scared of being addicted. And that's a big concern, because a lot of times these medications kind of have that negative connotation because they are so regulated and they are so watched over by both doctors, pharmacists, you know, and the DEA, of course. You need to talk to your doctor and see, what are my options, what are other alternatives, and, you know, is taking all these medications and spending all this cost on medications worth it? And granted, it just comes down to basically it's a communication. You know, it's communicating with your pharmacist, it's communicating with your doctor. That's what we're here for, that's what they're there for, you know, because we want for you to have the best outcome. We don't want you on 5 different medications to outweigh, you know, the side effects of one, and that's our job, is to try to kind of help you with managing not only your pain but managing your medications as well.
Thanks for that. There's a lot about pain medications, and but I personally believe that one of the most important things we can do for pain is to get moving, because I'm afraid that many people, the less they do, the more pain they have, and the more that they get moving, unless they have an inflammatory process, the more they can move through it, the more they can be active, the better. Bill, your comment.
Well, I think you're absolutely right, and I know you're an athlete, and as an athlete, I got a soundbite for you. How about motion is the lotion of joints?
There you go. And there's scientific data to say that when you are moving a joint, even if it's bone on bone, that joint gets better. It builds cartilage. It makes the lotion. Right. It makes the lotion. So we really encourage people who are in pain to realize that, particularly if it's chronic, that much of the answer is to get going now. Jim, you're looking skeptical.
No, a lot of them are weight depending on their bone. I usually try to get them in water if they're not afraid of water. It's very important from that standpoint to keep them in motion. It's not always convenient in smaller communities, so there are things you can do if you're trained how to do Pilates, special set of exercises. Walking doesn't seem like much, does a lot.
So I love those answers. There you go. Rehabilitation has to do a lot with motion. I was going to ask you about what kind of pain problems these people get when they come back from their experience overseas, these veterans that we're caring for.
A lot of bone and joint pain. I mean, the signature of the war basically is the explosions, you know, and the injuries. It's probably some of the most critical or most visualized things. But most, you know, bone and joint pain, musculoskeletal, and the reason why, the amount of load, just their body armor is 80 pounds. If you put it on a 150-pound frame, do that for a year, and just imagine walking with 80 pounds plus. That's without their pack and munitions on there. By the time they load it up, they have 100+ pounds every day.
Every day that they're carrying.
Every day.
Right. And then we got to add to that, you know, we think so frequently that people that come back from war have all been blown up or lost an arm, lost a leg. How about the people that weren't blown up, but were there during the accident, were there during the explosion, were thrown and come back with chronic pain, and you say, hey, you got all your fingers, you have all your shoulders, your legs, you're okay, get back and do it. Yeah. But they hurt and they have chronic pain, and it's legitimate and it's real, and they need somebody to understand. We understand it's there, and let's try to make it better.
How much of it do you think is this classic post-traumatic stress syndrome, this this adrenaline surge that happens when they become overwhelmed by the fear of it might happen again, or that this pain is going to continue, or that something bad has gone on in their lives. I mean, how would you describe post-traumatic stress syndrome?
You know, it's very serious stuff. It's legitimate, it's for real, but as we were saying during the break, I mean, all of us have PTSD to one degree or another. Think about the last time you had a nightmare of one more exam, and you and I were in medical school 45 years ago, and we're still dreaming about it.
I'm still having that dream.
So when you've been in, when you've lived through hell, when you've lived through war, and you have chronic pain, and every moment you have that pain, it reminds you of what happened. I mean, it's a nightmare. It's a continuing nightmare. So being able to relieve that pain helps the nightmare go away, because once it's gone, there's less to remember.
So to help, to summarize that, to help with the post-traumatic stress syndrome, the stress syndrome, better to relieve the pain first, and there's less stress. Any comments, Jim?
Oh, I've seen miraculous things on there when he effectively treated the pain. Their symptoms improve quite a bit with post-traumatic stress disorder. It doesn't win all of them, but a significant percentage where I've been impressed.
Okay. And I want to add to that you know, Dr. Hoff is a very humble guy. He has 5 board certifications. He's treated thousands of these people.
You mean this guy right over here?
Yeah, this guy over here. It's extraordinary, and the patients sometimes cry when they talk to me about him, about how.
Just a few ago.
I cry when I talk about him.
I mean, you know, Hoff will call his patients at 10 o'clock at night because he's still busy speaking to them. And, you know, for these patients, just acknowledging that you care about them means so much in helping them to get better. We understand. We're on your side. We're here for you. You're not here for us.
No, and also I think the value of touch. Physician's touch, the nurse's touch to the patient.
Right.
We've got a ton of questions. I'm going to run through. I want quick answers here. I want quick, good answers. Of course, spinal stenosis, is it usually the whole spine? How do you treat pain if bulging disc isn't bad enough?
A quick answer, right?
Yeah.
In one syllable, Jim?
Depends on the severity. The majority are not surgical on there. A good therapy program helps a significant number on there. But again, it depends on the severity of it.
That's right. I mean, and actually, surgery is not a great answer for pain.
No.
Rehabilitation is the answer for pain.
Actually, there's a lot of them that had surgery and it wasn't the answer for that.
It does
because
not.
They still had the symptoms.
If people want the MRI. That's a pre-surgical procedure, I call it. What about the person here from Vermilion had a whiplash injury? Oh, you wanted to say?
Yeah, I want to jump in. MRI is not the answer. The answer is a good history, a good physical, listening to the patient, figuring out what the problem is. MRI is end stage.
That's the last thing you do.
Right, not the first.
Not the first. The history.
Right.
Bingo. Vermilion, this person had a whiplash injury 35 years ago. They use hydrocodone for the pain. Are there other options to help her or him? Hydrocodone, good drug?
Actually, they probably get better relief with what you do, Bill.
Right. The first answer is not hydrocodone, anti-inflammatories. Number 2, exercise. Number 3, modification of lifestyle. Number 4, re-evaluation of the way you read the newspaper, watch TV, sit in a chair, stand, walk, exercise, all of that. And after all of that's done, then there are the things that I do, which would involve identification of the specific joint that was injured, finding the nerve that supplies that joint, and modifying the nerve without surgery.
Okay, good. Good answers. I would say, though, that nowadays there's been more and more against the non-steroidal anti-inflammatories, even though they're the mainstay, and people are being asked and encouraged, the literature is supporting this, to go toward the narcotics sooner when you do a drug. You and I are old school, but the truth is they're pushing more toward the hydrocodone.
Well, you know, literature is written by people like you and I. Because it's written doesn't mean it's so. Because it's there doesn't mean I agree with it. I think we need to be respectful of any drug that we use, and judicious application of any drug is the key.
Yeah, good. All right, Sioux, and we've got to roll in a minute about spinal stenosis. Sioux Falls have had problems with slip discs and lower back that prevent walking for years. Now has weak lower back and legs, and now needs wheelchair. What can be done? Progressive deterioration of function. Jim.
Boy, a really good exam for one, and what options there are. If they've been seen by somebody that does surgery and said there's nothing non-surgical on there, I've seen a lot of those through the years. You got to get them up moving on there.
They got to get moving, or they're going to get weaker and weaker.
The thing is it a structural lesion from the standpoint that's been damaged, like they've had an attempt at surgery before and get scar tissue, or nothing's really been done, they're sitting on the fence, and how to move around. A lot of them I really like to get into the water first to sort, but get
them going.
I like to look at the severity of what's going on.
Yeah, if you don't use it, you lose it. And if somebody has pain such that it disables them enough that they don't move, they'll get weaker, the pain will get worse, they'll get weaker, they'll move less. It's a terrible cycle. Just don't get yourself into that.
They spiral down.
They do. Here is a question: 3 back surgeries, 2 knees diagnosed with neuropathy, still having pain on those knees. 270 milligrams of gabapentin or 20 milligrams of Cymbalta, 120 tramadol. What more can be done? Hot Springs. I don't know how much gabapentin they're on. 27?
Probably 100 milligrams, I imagine.
Yeah. A lot of gabapentin. They're on max medication. Rehabilitation.
I'd have to look at them. Again, movement's real important on there, but it might be weight dependent. I get the rare bird that comes through where they're kind of reactors in metal when they put it in on there and they get sore. I treat them a little bit, but usually they're functional a lot more. The important part, like you said, keep moving. The medications on there, gabapentin doesn't necessarily work for direct bone pain. That's more for nerve type pain. An assessment, the tramadol is a reasonable medication, or the Ultram that they're on.
Yeah. Right. Tough issue. I would say this, that I've seen more low vitamin D and in these osteoporosis patients, so we need to realize that early on people should be checking their vitamin D levels. I'm a real fan of that one. And so
I think you'll be shocked at the numbers that I find.
Unbelievable.
I am absolutely
low
shocked.
levels of vitamin D, and that gives osteoporosis, osteomalacia. We need to move on, Jim.
Okay.
As we have seen, all pain medications can have some negative effects, especially when they're used over a long period of time. On Call recently visited with a pain sufferer who seems to have found a reasonable alternative to drugs when it comes to chronic pain relief.
With my back, my spine, I have scoliosis, which causes my spine to be twisted. It forms a little bit of an S and a little bit of a twist. It's also caused my left hip to be slightly out of socket and to have no curve in my neck, where most people have that bow in their spine and their neck. I don't have that. It's straight, so it causes a lot of headaches and a lot of pain. So I've done the best I could over time to trying to develop a workout and training method to help, as it's not going to go away. I've had this since I was 13, so 21 years now I've been dealing with this. It's only been probably the last 15 years of my life that it's really started to cause the pain, and it slowly builds. The pain slowly gets a little worse over time, so I find it's important to try and do things to minimize that. I started training in the martial arts almost 9 years ago, and that started to do significant differences for me. I think one of the things that really helps is stretching, daily stretching. So I stretch lightly in the morning, heavy at night, and training the martial arts has done a lot. And outside of the martial arts, that's when I found out about the yoga class. Yoga's been the ideal addition to my training, and it's done a lot of good. It's definitely reduced a lot of my joint pain. With the pain pills, I've never gone that route. I don't feel that that's a route I want to take. For me, that's going to be the last resort. It's going to have to get really, really bad. Going into yoga, started that in the fall, and I realized real quick on that I was having some more joint pain gone, especially in my hip. I'm starting to be able to sit down and sit up without as much hip pain. I'm throwing kicks better, and some kicks that I could never really do before, I'm starting to be able to do just because of the joint pain. And it's helping with my headaches. It seems like it's helping a little bit with my asthma as well. So it's definitely something that's going to permanently be into my training. I found that having a chronic pain issue, I figure you got a couple different ways you can look at it in life. You can't really so much deal with the cards that you're dealt. You just got to be able to roll with the punches. And some people never get to walk. You know, some people got to walk around in a wheelchair. They got a crutch. They got a bad mental illness. Me, I figure, you know, I got a little bit of a twisted spine. I get some pain. I don't feel that God gives us more than we can handle. For whatever the reason, we're given what we're given, and it's actually been a blessing in a way for me. Without it, I may not be, and I probably won't be the martial artist I am today, and I've gone on to accomplish what I have with the martial arts. I think stretching is a big key. I tell everybody every day, you should stretch every day. You should have one good kata you do every day. So the stretching has been, it's probably more important than anything, to be honest.
So we've got more questions. We might just jump in. That was quite a story, though, and I love the idea of being active, keep going to be part of the rehabilitation of getting back into life.
Well, treatment of pain is many things. Activities, judicious use of meds when appropriate. That's very important. And, you know, other things that can be used to help it. It's not all about the medications. It's multiple factors. Just relaxation techniques can offer wonderful relief for somebody.
So lots more than just pills, pills, pills. That's what we, you know, our whole country has moved in that direction, and part of it has been the industry. Thank goodness for the good pharmacy industry and the research that they're doing. I'm not negative about it. I would say, though, that there are more ways to treat than just pills.
Yes. I'm still looking for pill for motivation.
Yeah. We have an Aberdeen caller. Relative has chronic migraines. Has had migraines for over 3 months. Does one migraine headache for 3 months. Does pain doctor have any ideas?
Well, the question is, what is a migraine?
Yeah, what is a migraine?
And we spoke about this 3 or 4 years ago when we were on with a physiatrist and a neurologist. The term migraine is frequently used to describe any significant headache of any kind. But headaches have lots of different causes. The cause can be either something cerebral, whether it's a brain tumor. It could be from a vascular problem. It could be a hangover. It could be because you have a musculoskeletal problem. You fell, you injured yourself.
Arthritis in the neck.
Right, or you could be a cheerleader or an athlete that jumps up and down a lot and has trauma. Or you can be a drill sergeant who's done 150 jumps out of an airplane. All of these things are different causes. So when you say a migraine for 3 months, again, you really need to have it evaluated, come up with a reason why there's a headache, and is it what kind of migraine is it? Is it vascular? Do you wake up with it? Do you go to sleep with it? When does it come about? How is it? Does it get worse? Does it get better? And then from that, have an evaluation, examine the patient, come up with an answer.
Right. You know, migraine does not mean severe. Migraine, it means maybe an etiology, maybe, and this person with 3 months of headache may very well not have a vascular headache, which is by some people's definition the cause of a migraine. Good point. Any other comment?
Well, there are at least 6 different categories of headaches, and I usually will work through it systematically to look which way. There's a lot of them that have mixed factors. You know, something in the neck, and then they might have a true migraine, but the neck triggers the migraine, or more susceptible to go out. You get one factor treated, the rest of it settles down.
I know of people who, and I had, I think, a migraine headache triggered by sinus congestion, which was triggered by a viral infection. The treatment of choice was, and also by coffee, too much coffee in the morning and then not enough coffee in the evening, and then there's this coffee change in your body, and that would trigger the headache.
Or you could have a patient who's hypertensive who may have taken a nasal spray because their sinuses are clogged and they're on the verge of a stroke, and that headache is telling them. I mean, there's all sorts of problems.
It's a specialty in and of itself. In and of itself. We have history. Question of fibromyalgia. Do you have this person is on gabapentin, takes swim therapy, but some days nothing works. What else can she try? I had one specialist talk about the lack of consistent and enough sleep, and that my physician friend said sleep is a very important issue here. Any comments about fibromyalgia?
Multiple things are needed for fibromyalgia on there. It's a highly debated diagnosis, between the different specialties on there. The things that I found through the years, exercise is extremely important in this. They need their little hideaways. The majority of them, if they got a hot tub or access to one, that's their little hideaway to feel better, at least, to get a break from it. Sleep is part of it. They've got different theories on it, but they had one like a yeast theory. I've never seen it pan out in anybody, but
no.
They wrote about it anyway, got somebody published. But
yeah.
Medications, a lot of them fall in the trap of opioids, medications with narcotics.
Bad choice.
For that, you shouldn't fall in that trap. If there's associated arthritis, but there's different ways you can treat it too, because I've had a few people get treated and it melted away, but it's under a unique thing. Is it post-traumatic? Etiology of this.
The cause?
What's the cause?
Yep.
All right, well, let's just define what fibromyalgia is in the first place.
Tell me what it is.
It's a wastebasket term that's used for a variety of symptoms. Our friends in rheumatology, in physiatry, and neurology, some orthopods, describe it as having 18 specific sites that you need to evaluate to determine if it's there in the upper body. For instance, the shoulder, between the shoulder blades, going down, in the armpit, the anterior chest wall.
Just sensitive to touch when you push
all
them.
those areas, and just using the same amount of pressure at each one of the areas will elicit different types of pain. Looking at the neck or in the back of the head, some people call it neuralgia, occipital neuralgia. But in fact, frequently, if it does have an etiology, which is a word that we use for cause that comes from a trauma, if it's musculoskeletal, it can frequently come from an injury to the neck. So the ways to treat it will be, number one, simple massage, gentle treatment of it. If it's from the neck, taking ice, putting it on the back of the neck, taking moderate amounts of medication for short periods of time to see if it makes a difference. Having a good bed with a nice solid bed, not a water bed. Looking at your posture, exercising, walking more, and then there's a variety of much more interventional modes. But usually intelligent behavior, like what your friend, the doctor had said about sleeping well.
Yeah.
Good sleep hygiene, personal habits, the way you sit at the computer, the way you sit in the chair, your posture, all of those things. I mean, I'm very eclectic with the management of it, and usually look to medications last. See your chiropractor, see your massage therapist, see your medical doctor. Speak to somebody before you treat it yourself. But intelligent evaluation of it can lead to a good cure.
And try to do the healthy things in the daily life. Look at the things that might be triggering it. I personally do like utilizing SSRIs or the antidepressant group, not because these people may be depressed, although they may be, or they may be depressed because they hurt, but because I've seen a lot of help with the SSRIs, like Prozac and like sertraline and a variety of others, because it helps with pain. In some people, the pain is better.
Well, remember, in the United States, it's a sin to have pain, and we want a pill for everything.
Yeah. We got 1 minute. I wake up with pain in my hip. It shoots down my leg while I'm walking. What do you think it is? Back.
Depends, front, back, or side of the hip. Towards the front and the groin, it could be the hip socket itself.
Front is the groin. In the groin, that could be hip.
Yeah. To the back, it might be the lower spine.
Right, and if it's on the
side,
epitrocanteric bursa, then what is it?
You may have a bursitis on there. There's a kind of a piece of gristle that comes on there that sometimes gets inflamed.
Do you like to inject people with joint pain?
I do it on there, but steroids, if it helps retain function, it's kind of like having a beer, Rick. Depends how big and how much.
How many beers?
A little bit won't be so bad. A lot of it really gets to be a problem.
All right.
But if you have an approach that uses a little bit of each, it's better than a lot of one.
All right. Good. Sometimes in the 1960s, sometime in there, I remember my dad telling me that he didn't need health insurance. He said that for his efforts in World War II, he was promised to always have health care when he needed it, and that it would be provided for free by the government. He proudly asserted that in this country, we take care of our own. The U.S. Department of Veterans Affairs, or the lovingly known as the VA, provides for health care of the soldier after her or his service to the country. I don't think my dad had it quite right about totally free health care for all retired soldiers, but I think he was correct about our country providing care when needed. Indeed, the VA provides in a very big way for many men and women who have given military service to our country, and the need for especially rehabilitation type care is on the rise. During military conflicts in Iraq and Afghanistan, and because of superb emergency and intensive modern health treatment there, soldiers have survived like never before after sustaining tremendous injuries. The VA has had to develop and enhance ways to enable injured soldiers back to function in society. This defines rehabilitation, which is accomplished by providing physical therapy to enhance strength and mobility, occupational therapy to teach and improve ways to do activities of daily living, speech and language therapy to augment communication skills that may have been compromised by injury, and psychiatric support for those struggling with post-traumatic stress syndrome and other mental health injuries resulting from war. Finally, and perhaps most challenging though, rehabilitation requires adequate treatment for the physical and psychological pain resulting from injuries of combat. Our country has a special responsibility for those who we put in harm's way. First, to provide the very best emergency and intensive care possible in order to save their lives. But then when they do survive, we need to do everything we can to provide rehabilitation. If we're going to enter into these conflicts, we had better take care of our own. So, comments. Bill?
Each one of these heroes is a hero there and a hero when they come back. It's important never to forget what they've done for us, and for each of us to do our part to help them continue to be mentors for each of us, because their healing will affect those who haven't been to war, who have pain also, and their perspective and their behavior can help us to learn more in helping others.
Right, that's beautiful.
I've had the honor of working with these gentlemen, and I tell them that. That's why I'm there.
You know, that gives you a sense of, I would imagine, a great sense of reward for having an opportunity to help these people.
Rebuilding lives and priceless.
Yeah. Do you feel that some of those lives are not rebuildable?
I see a lot of things on there, and it's very difficult. Each case is different. You try to make it unique. I have a unique practice. It's a very tough practice. I love these guys. They're willing to take a bullet for this country and do anything that it takes. They deserve that respect. They should be taken care of. But one case at a time is kind of my motto. And how can I best help them? And sometimes it doesn't take much.
And sometimes it takes a bunch.
Yes.
But the key is to let them know that we are thankful. The first thing I say to every patient is, thank you for your service to America. It's my turn to serve you.
Yes. You know, isn't it a switch around? I remember when my buddies were coming back from Vietnam, and the country was mad. They were mad at the soldiers even. And we've all learned from that experience. I mean, it's changed. It's changed. We've got about a minute to wrap up. Any take-home messages about pain that we want to make sure that they have it? You can repeat yourself. What would be the most important take-home, Jim?
Never give up, never give in. There's usually somebody there that can help you. You want to find somebody, obviously kind and caring. The other thing you can do is be organized. Specific things of your history, all your medications, your records, and go on there, where you've been, and where you've tried to receive help from. It tells a lot. even the greatest technology doesn't always help these people, and where I found out some of the simplest things actually help.
And don't be afraid to ask. Ask your doctor why your problem is there. And if you don't get an answer, find a doctor who will give you an answer. Keep pursuing the truth.
Very good. Well, that wraps up our show for this evening. I hope we have provided you with effective pain relief information. I sincerely thank our video guests tonight, Dr. Jim Hoff, a specialist in physical medicine and rehabilitation at the Sioux Falls VA, and Dr. William Cohen, a pain management specialist at the American Pain Relief Institute located at Avera Sacred Heart Hospital. And thank you, our viewers, for watching. Your questions and input do make a difference. Until next time, stay healthy, people out there.
Is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.